We'll start in another 2 minutes.
Hi Chandi, hello, and hi Nishan. Some familiar names here.
Hello, good evening, Dr. Deepak.
Oh no, I think for you my home name will be absolutely fine. You know me from way back there. Okay, brilliant. Excellent. Hi, Daritri. Oh,
Utterly,
fantastic.
doctor to call doctors on first name basis. Utterly dangerous.
No, no, she's also related to me, absolutely. So that's one of the few times I some people can exercise privilege.
Thank you, Balaji.
Brilliant, lovely. Thank you so much. Wonderful. We've got a good spread from all the main cities in India, as I can see, and as well. Thank you. Hopefully, it'll be a good start out there. Brilliant. I will just actually at the same time.
We'll just start, Dr. Deepak,
Yeah,
and
yeah,
people will.
absolutely. I think I'll just thank you and I'll hand over to you, Pratik.
Yeah. Okay. Hi. Good morning. Good afternoon. Good evening, everyone who joined. I'm Pratik. I'm from Delhi, India. This welcome to the webinar. This is titled as Living with Pain, and this has been organized by Blooming in Pain in collaboration with Dr. Deepak Ravindran, as you can see, and Professor Cormac from Flippin Pain. We've just I mean around 2 minutes of background, and we'll start. We've realized that pain is fundamentally one of the most universal experiences in this world. One of the most fundamental experiences. Yet when it becomes chronic and persistent, it somehow becomes invisible. And somehow becomes just extremely difficult to speak about to your parents, to your families, to your colleagues, and of course to one's own doctors and medical supervisors. So uh, today's webinar is just an attempt to give a language to that experience, uh, to give a language for us to articulate how we live with pain, how we speak about it, how we frame it, how we reframe it, and how we speak about it as an experience to people around us. Um, I myself, my primary role in Delhi, India, is that I lead a disability organization and I'm a disability activist. But I also have a lived experience of um, of living with fibromyalgia, which I was diagnosed around 5 years ago, just after COVID, and after around 3 years of navigating around 25 plus doctors in 4 Indian states and undergoing around 200 physiotherapy sessions, I started writing about it. And since I started writing about it, I saw many young people coming out to me having nearly similar experiences of being in pain. And I realized that it takes just too much time for us to even accept that things are changing body and in the world that we live with. So it's just about me. I'm right? Audio visible?
Sorry, what was that, Pratik? Yeah, you're visible and audible. Yeah.
Okay. That,
Sorry, now you broke up.
so yeah, I mean, I think that. Am I audible now?
Yeah, you're audible now. Yeah, absolutely.
Okay, thanks. Purchase. So this was just about me. Over the next 2 hours, we'll try and explore that why pain can continue even when disease markers are stable, how persistent pain is shaped by biological, psychological, social factors, and many indicators and factors like sleep, stress, movement, medication. We will also try and reflect on the communication gap between us and our body, but also on the wider external communication gap of between patients and caregivers, between patients and clinicians, between patients and their families and their workspace. Um, this conversation will also touch upon cultural narratives which are there with patients. I mean, around endurance, around stigma, around guilt, around invisibility, um, and of course might be able to help some of us to develop the language of pain and strengthen self-advocacy, while also deeply recognizing that pain is a lived human experience and can be different for everyone. Um, before we start, we have a short survey we would want you to fill. It will just take 3-4 minutes and would really help us to take the conversation forward. So I'll ask Dr. Deepak to just help us out and uh, share the link and the QR code, and then we'll take it on from there.
Fantastic. Well, thank you so much. I have just shared the link in the chat as well for some of you who may be logging on to this from the mobile phone. This is there in the chat itself. The Google form takes less than 2 minutes. In fact, Pratik said 4 minutes. I've actually tested it out. It takes less than 2 minutes to fill out. It really helps us because the main purpose of this is going to be setting the stage for having some kind of a pain education awareness initiative in many other countries. I think we've been singularly fortunate to have Prof. Cormac Ryan and organizations like the Flippin Pain in the United Kingdom, and we've seen how much of a difference it has made to how people, public health, and the general public understand and recognize. And I think this is definitely required in many other countries as well. So part of our option is to see whether we can have a similar thing starting in other countries as well. So if you can just help us out here, for those of you who are on a laptop, here's the QR code that you can scan. And for those of you who are in the mobile phone, please use the Google form link in the chat. Pratik or Simi, for those who have come in new in the last couple of minutes, the chat may not show it. So could you just repost that link, please, in the chat?
Yeah, sure.
Thank you, Simi.
So for those of you who've just joined, we've got a pre-event survey. It will take 2 minutes. We have a QR code in front and on the screen, and we also have a link on the chat. If you would
Many
just
of
take
you
a
may
couple
have,
of minutes to fill.
yeah, many of you may have done this as part of your registration. If you've already done it, then there's no need to do it again. But for many of you who just come in this morning or come in through the Zoom link, then please do help us out. As I said, there is a plan to actually use the response from today's webinar, both a pre-event and then there's a post-event. And more importantly, as a little bit of an incentive there, I've got some of the resources for managing and supporting people with pain that we have in the UK, as well as things that I offer in my clinical service there. These are some of the resources that I'm happy to freely share with everyone who at the end completes the post-event survey. For us, It's a great way to see how this webinar lands and whether it achieves its purpose, and the output from this is going to help us shape the kind of research we want to take for introducing pain education initiatives outside of the UK. So many thanks for joining in today. We've got a wonderful response. It's more than 40 people now, so it's great to have this kind of a response on a Sunday afternoon, brilliant, or Sunday morning. Right, Pratik, let me know when a couple of minutes are up. I think for those who had the scan there, I'm just going to stop sharing now. Hopefully you've had the QR code. You still got the link in the chat. Right.
So people who've been able to fill up the form, can they just give me a thumbs up and then we'll start?
Thanks, Prachi. Excellent. Right, wonderful.
Okay, so we'll start in. I mean, the first half of the webinar is where both of our collaborators, Professor Cormac Ryan and Dr. Deepak, would be speaking. I've advised them to stick to the time, so that's what we've done. But I'll ask I'll ask Cormac to start and just a little bit about him. He's a professor at Teesside University and originally trained as a physiotherapist. I myself had multiple experiences with physios here in India, but he's a globally recognized leader in pain science education. Has now extensively worked with this community campaign called Flippin Pain, and authored more than 100 research papers on improving the public understanding of pain. And Flipping Pain is an international public health campaign that aims to change the way people understand and respond to persistent pain. We've asked Professor Cormac to help us navigate the understanding and experiences of chronic pain and tell us something new about it, about chronic pain which we don't know, and how to reframe chronic pain for us. So the floor is yours, Professor Cormac, and thanks for joining.
Thank you very much, Pratik. That's a really nice introduction. Very kind. Let me see if I can share my slides. Share. And share it as a slideshow. Right. Can you guys see those slides?
It needs to go into slideshow. It's gone into slideshow mode. Wonderful.
Perfect. Wonderful. Okay, so can I first start by thanking everyone for the invite to present today. I'm going to press start on my stopwatch, so I'm going to stay within the time that Pratik has set me. So I'm Professor of Clinical Rehabilitation at Teesside University. I'm also a community pain champion for the Flippin Pain campaign, which is a public health campaign which tries to change public understanding of persistent pain based in the UK. I was in India about 2 years ago. The sort of warmth and friendliness of the people was only matched by the tastiness of the food, the beauty of the scenery, and the chaos of the traffic. It was a fantastic time, and it's lovely to be back even virtually. So thank you once again for the invitation. So how does the average person think that pain works? The average man on the street. When I asked Google to give me a picture of the average man on the street, this is the picture that Google gave me. I can't help but feel that Google has an unrealistic image of what the average man on the street might look like. But I believe the average person believes that pain only occurs when you are injured. The greater the injury, the greater the pain will be. And the persistent pain always means the injury has not healed. Now, those seem like perfectly logical statements, but actually they are all misconceptions. They are all myths about how pain works, and they act as barriers to good management. Over the past 80 years, within the scientific community, we've learned an awful lot about how persistent pain works, but very little of that information has passed through to the person on the street. And as such, these myths and misconceptions, they linger on, creating a huge barrier to good management and fostering stigma. At the Flippin Pain campaign, we believe that knowledge is the key to success. If we can take all of this scientific information and put it into the hands of the people who need it the most, the person with pain, their friends, their relatives, their healthcare professionals, we believe we can bust many of these myths, leading to better pain management for all. We're trying to change the way that people think about, talk about, and treat persistent pain by communicating 6 key messages: that persistent pain is common and can affect anyone. Hurt does not always mean harm. Everything matters when it comes to pain. Medicines and surgeries are often not the answer. Understanding your pain can be key, and recovery is possible. Today, I'm going to just focus in on 2 of these very briefly. That hurt does not always mean harm, and everything matters when it comes to pain. So what does this first one mean? That hurt does not always mean harm. Well, this is one of those key misconceptions that we talked about. Take a look at this case study. It was published in the British Medical Journal in 1995, and it tells the story of a builder who jumped from one platform to the next, and as he did so, a 6-inch nail went up through his boot. He was in absolute agony, rushed to accident and emergency, where they gave him some really strong painkillers like fentanyl, but it had very little impact. They removed his boot, and what they found was, miraculously, the nail had passed between his toes. So there wasn't a scratch on him. He was completely uninjured, yet he was in terrible, terrible pain. It's a perfect example of hurt does not necessarily mean harm. You can have terrible pain with little or no tissue injury. And the reverse is true. This is a case study published in the journal Injury Prevention of a man who was unaware that he had a knife stuck in his head. A quick disclaimer, this is not the picture from the case study. There was no picture with the case study. I took this from Google. In this case study, a man came into, again, accident and emergency, complaining of some headaches. When they scanned him, they found a 12-centimeter knife was stuck in his head. It turns out that the night before he had gotten a little drunk, fallen off his stool, and when he woke up the following morning, he could find the handle of his favourite knife, but he couldn't find the blade. No prizes for guessing where the blade was. 2 days later, they removed it, and he left in pretty good shape for a man who had had a knife stuck in his head. It's another perfect example of hurt does not necessarily mean harm. You can have terrible injury with little or no pain. Pain and injury are 2 separate things. They sometimes hang out together, but not always. And over time, they drift further and further apart. Now, you might be thinking to yourself, these are really unusual people. They're not like me and my friends and family. They don't represent normal people. But this sort of thing happens every day. Have you ever been involved in an activity, really engaged in it, whether it was playing cricket, some other sport, or cooking, or just doing something you were really engaged with, and then noticed that you were bleeding and gone, how did that happen? I'm totally unaware of that. Or have you ever woken up in the morning and looked at your leg and gone, where did that bruise come from? I have no recollection of that bruise happening. These are all mini examples of hurt does not mean harm, where an injury has occurred, but little or no pain was experienced. So that's the first key message, that hurt does not always mean harm. And if you take nothing more from my part of today, that's the key one I'd like you to take on board. Now, that brings me on to the second key message from me, which is that how is this possible? How can you have terrible pain with no injury and terrible injury with no pain? And it's all to do with this key message that everything matters when it comes to pain. Pain is a biopsychosocial experience influenced by biological, psychological, and social things. But to discuss this first, I'm not going to talk about pain. I'm going to talk about vision and how our visual system works. Because everything we see is a biopsychosocial experience influenced by biological, psychological, and social things. Take a look at this cube. You'll see that the two squares that are circled, the top one looks like it is brown and the bottom one looks like it is orange. But when we put a white sheet and just cut out those two squares, it now looks like the bottom square has turned to being brown and they both look like they're the same color. Now, actually, I haven't changed the color of that square. The only thing I've done is put this white sheet around it. So how does that happen? How does it magically appear to change color? Well, it's all to do with how our visual system works. Light reflects off images in the surrounding area, goes in through the lens of our eye, and is projected onto the retina at the back of the eye, where it stimulates little receptors, converting the message into electrical energy, the light energy into electrical energy, where it's sent to the part of the brain that deals with vision. Now, I want you to imagine that in there is a little girl called Sheila. Sheila is surrounded by millions of jigsaw puzzle pieces. She uses those jigsaw puzzle pieces to build in real time an image of what she predicts to be going on around you. And that's what you see 100% of the time, all of the time. Everything you see is not necessarily what is physically actually there. It's your brain's representation of what is there. And lots of times it's correct. Most of the time it's correct. But sometimes it's inaccurate. So if we take this information, and it's influenced not just by the light information that comes in, but it's also influenced by our previous experiences, our expectations, our beliefs, our attitudes. Everything matters when it comes to what you see. So if we take this information and bring it back to this illusion, we see that there's what appears to be shadow to the left of the cube, suggesting light coming from the other side. Now, this is not the case. This is a 2D image, not a 3D image. But Sheila has evolved to deal with 3D image. So she's assuming that that shadow is real and the light is real. So when she receives information from this screen, we know that in reality, in the external world, these are both brown squares. They're both the same color. So the same amount of light energy is reflecting off both squares, going in through our eyes and reaching Sheila. Sheila would usually say, same amount of light energy, they must be the same color, they must both be brown, and thus that's the image I'm going to create. But then she goes, wait a second. If that bottom square is in a darker area because of the shadow, it must be a brighter color. And thus she predicts that that bottom square is orange and that top square stays brown. And thus that is the image she creates for us 100% of the time, all of the time, for every single one of us. Now, even though we now consciously know that that bottom square is brown, or we know that that's kind of the external truth, even though we now know that, as soon as we take the white sheet away, Sheila immediately turns it back to being orange. In other words, we don't consciously control what we see. Our unconscious brain, our Sheila, controls what we see. But sometimes we can influence her. Now, I want to introduce you to Assumpta. Assumpta is the part of the brain that deals with pain. She's like Sheila's first cousin. I like to depict her as Lady Justice, with her blindfold and her weighing scales. When she receives danger messages from the body, equivalent to the light messages that Sheila receives, Assumpta asks, how dangerous is this really? If, on balance, she believes the situation is dangerous, she will want to draw your attention to it and get you to do something about it, and thus she'll produce the experience of pain. In contrast, if she believes the situation is not dangerous, she will not want to draw your attention to it, not want to get you to do something about it, and not produce the experience of pain. It's as easy and as difficult to get your head around as that. But what happens in persistent long-term pain? In persistent long-term pain, this alarm system, our pain alarm system, becomes supercharged. It becomes overprotective. Assumptive scales get tipped towards danger all the time, so they're more likely to be set off. You could liken it to an overactive or an oversensitive car alarm that's not just set off when there's damage to the car or when someone's trying to burgle it or break into it, but it also gets set off when perfectly safe things happen, like someone walks past it or there's a simple gust of wind. And the alarm sounds just like it does when someone's trying to do something bad to it. And this kind of communicates that pain is a marker of perceived threat. It's not so much due to tissue damage, but the increased sensitivity of our body's natural alarm system. And the purpose of that pain is to protect you. It is to keep you safe, just like a car alarm is there to protect the car. But sometimes it becomes overprotective. Anything that suggests danger increases the sensitivity of the alarm system. Anything that suggests safety reduces the sensitivity of the alarm system. So stress and low mood can increase the sensitivity of the alarm system. What friends and family think, if friends and family are worried about what might be going on, that increases the sensitivity of the alarm system. Things like feeling financially insecure increase the sensitivity of the alarm system. This always astounds me that even a threat that's not specific to the bodily area can increase the sensitivity of that alarm system. Worry or fear about what the pain might mean can increase the sensitivity of the alarm. Poor diet, poor sleep, low levels of physical activity all increase the sensitivity of the alarm. Negative past experiences and trauma and loneliness, all of these things can increase the sensitivity of the alarm system. But just like they can increase them, if we work on them, we can also reduce the sensitivity of that alarm system. And Deepak is going to talk a little bit more about that later. So just to recap, 2 key messages for today. Hurt does not always mean harm, and everything matters when it comes to pain. If you want to hear more or find out more, go check on all these websites. Obviously, I would recommend the Flippin Pain website the most, but they're all pretty good. And I just want to finish by thanking Pain Revolution in Australia, led by Professor Lorimer Mosley. The Flippin Pain campaign really is led and takes the lead of Pain Revolution, and we're indebted to everything they share and support us with. Thank you so much. That's me. 15 minutes and 16 seconds, Pratik.
Thanks, Professor. Well, you could have taken a couple of minutes more, but thanks so much. Very insightful. I have a couple of questions, but I'll stop myself and I will probably turn to Dr. Deepak for his address, and then we'll probably open it up. I mean, Dr. Deepak has been kind with me, and we've been in touch for quite many months now. Has been beneficial for me for my own understanding of pain and how does one live with pain. He's an Oxford and London trained NHS consultant, and has more than 2 decades of now experience of working with pain and people living with pain. Is the director of this amazing clinic called Berkshire Pain Clinic, and is also an award-winning educator and the author of Pain Free Mindset, which I've read myself. Over my last few months of conversations with him, I've understood about my own body and how does really pain work out in all the biopsychosocial factors. So The floor is yours, Dr. Deepak, and then after your address, we'll make it open.
Okay, thank you so much. Just let me know, Pratik, when the slideshow then comes into place there. Make sure as well that I've got my recording in place there.
That's here. If you could just do it slide.
Yeah, go to the slideshow mode. Okay. Is
Yeah.
that all right? There's no band or anything coming through, isn't it?
That's good.
Right. Right. So taking that cue on from what Cormac has talked about there. So welcome all this morning. Good morning, good afternoon, good evening to wherever you are logging in from. To me, that knowledge that I have gained in the last 5-10 years of understanding pain science, the work that I've done with Cormac and with organizations like Flippin Pain, has made me change my clinical practice itself to the extent that now I feel very confident that there are many hopeful ways of tackling persistent or chronic pain, whichever way you call it there. So a little bit about myself. I've been born and brought up in India. I trained in Pondicherry, in Jipmer, and I have then spent my time from Hyderabad and now in the UK for more than 20 years. Have had the fortune of working with many wonderful people across many parts of the UK. And right now I stay in a place called Berkshire, which is a state sort of adjacent to London. And I've got my both practice in pain and lifestyle medicine. My clinical practice essentially involved this kind of statements often that I kept hearing in the initial parts of my career. I started out as a consultant in 2010 within the National Health Service here. And often I would get these kind of statements from patients saying, I saw either a physio or a surgeon who said this pain should have gone in 3 months, but it hasn't gone. What are you going to do now? Or a surgeon or would have told the patient that they have never seen such severe arthritis like this before. The worst and very unusual things were, and one of the very big lived advocates in the UK often says this, he said that actually his spine was compared by his surgeon like it was a crumbling biscuit, a Marie biscuit. Can you imagine what it would do to your brain and your body if what Cormac says that we will tend to worry? Imagine if you were told that one of the most stabilizing structures in your body is like a crumbling biscuit. I mean, that is absolutely so far from the truth, but that is the kind of language, unfortunately, that we are often hearing from many people. The most common one, of course, is this kind of statement that comes in the clinic where somebody had told me, oh, my arthritis is there, it's in the family, and then I had this accident, and the accident has now made my arthritis accelerate by 5, 10, 15, depending on who you see. This is one term I use as well. And what I am here to tell you is that all of this has really been challenged and questioned. And I would be putting the statement to you to say that 50%, more than 50% of what we learned in medical school is now being shown to be wrong or outdated or not accurate at all. You know the biggest challenge we have? The biggest challenge is we don't know which 50% and we keep fighting with each other on what that 50% ought to be. And I don't know if you face this in your journey across multiple specialists, the kind of language or the opinions or the thoughts they hear. And this is a big challenge. And this is a globally accepted challenge that it is when communicating about pain, when talking about pain and what it means for somebody's story. And a lot of it is not helped because we've got this paradigm or the way, the framework that we operate in many hospitals and many medical schools and healthcare schools is we don't see the whole person. We have now got multiple specialists and super specialists for each little organ and each part of the body that sometimes we fail to see the person in all of this. And that is very crucial because pain is a phenomenon of biopsychosocial. And as I like to think about it, is maybe better to start as a socio-psycho-biological phenomenon that we are talking about rather than something that comes from only a part of the body. And not only is this paradigm and framework very reductionistic because it becomes into little organ bits, It is also very fragmented because often each specialist doesn't talk to the other specialist. Each person is an expert in their own domain, and sometimes you don't have someone putting it together. In the United Kingdom, I think our general physicians, GPs, do a wonderful job in primary care of trying to keep some things together. But I know that this is a big challenge in some countries like India and in many other places where there isn't necessarily that respect given to someone who's able to integrate and see the person as a whole right from the outset. So my talk today is going to lead on from what Cormac has talked about, is essentially now hopefully you have understood what the new research around pain is, what pain really is. There are many reasons for why pain can persist, because persistent pain to me is a explanation and is more a manifestation of all of those factors affecting the systems. My main thing to say for you, and this is actually now come into the proper guidelines, like the International Association for Study of Pain, which is like the major flagship organization for persistent and chronic pain management globally, has said that there is a difference between these two words that you see on the screen. And so one of the words I'm going to introduce with you today for you to take away is this word called nociception. Just a new word, one for today, is essentially this is the term for the all the biological chemicals that get released at the site of injury. Now that may be a chemical, that may be heat, that may be fracture, that may be surgery, that may be inflammation, whatever it is, it will release some chemicals at the site. Now whether you had a surgery, whether you had an inflammation of your lupus or your autoimmune arthritis, whether you had a fracture or after playing or falling, there are chemicals released at the site of wherever that originated pain starts or that sensation starts. That chemical being released and converted into an electrical signal, all of that comes under the heading of nociception. Okay? And now what I want to tell you is that that's not pain. That is just the nociceptive signals at the site of injury or inflammation. Now, those signals will have to travel in the nervous system. First, they will go to the spinal cord, then they will go to the brain. And the brain, then, with all of what you heard from Cormac, the Assumptor, the Department of Health and Safety, Sheila, the person who's looking out, all of these people and all of the other structures and circuits and various parts of the brain will have to decide, do we need to protect? Do we need to do something to ensure the safety of this person? And if the decision, it can happen in split second, even at a subconscious level, if that decision is yes, I need to protect, then one of the main ways that protection can be brought about is by bringing about the experience of what we all call as pain. That is a fundamental difference. So pain and nociception are very different. That's what the new guidelines, and this guideline has been put in 2020 and it has now been brought into the UK guidelines and European guidelines by 2021, but it is still not really new mainstream news as yet. Why? This is very crucial because, just to put a flavor on it, if you do have the site of injury, if you do have that area of influence, and that spinal cord is taking up that signal and changing it, the nociceptive signal, I told you that the brain is making this decision on how to protect. But this is the new information. The brain actually has this capacity, like all these large language models and AI that you talk about, is that it decides on how to protect based on a variety of predictions and algorithms that are there in place. Now it makes all these predictions. So remember that prediction is not necessarily the certainty of fact. Prediction means it has received some prior information before, it has been trained on the prior information, and based on the new information that comes, it decides, compares it to the prior information and says, I need to protect, so I'll bring about the element of pain. So the question you must be asking is, well, how is the brain making and arriving at these predictions and training it? What is happening? Where is the training coming from? And that is what we now realize, is that training model, that information about how to protect, when to protect, what all to protect from, and what to look out from, it can come from the inside, the internal part. And by internal, it can be the gut. It can be what you eat, when you eat, how much you eat. It can be external. So it can be on the surface of the body. So injury, inflammation, fracture. But it need not just be on the body. It can be body adjacent. So what is happening in the ecosystem around you, the home that you're part of, the community you're part of, the society you're part of, the country you're part of, all of these are still giving valid information to your brain to say when to protect. The social media, the digital media, the influencers, people you see, all of this makes a part. And then, of course, we are now recognizing that these models could be trained by what happened in childhood. So if you've had significant adversities or traumas in childhood, that all can shape and can be protective algorithms and predictions that are in there. And it might take a relatively trivial back injury or a knee twist or an ankle twist or something in adulthood to set off those algorithms in place. And this is really collation of research information that is very well established and understood better now, to the extent that we have now got these three kinds of pain that we need to be aware of. So we are saying that when you do have acute injury, that is called nociceptive pain. When you do have nerve damage, that is called neuropathic pain, where the nerve has been damaged or affected. But there are these conditions where the nervous system can be sensitized. It can be sensitized by the information from the internal, from the immune system, from the gut. It can be sensitized by information that is coming from the immediate society and influence what it sees, what it hears, what the eyes do, what the nose smells, what the ears hear. All of the sensations can sensitize the nervous and immune system, and it can be about trauma, threat, other things also that can sensitize. That kind of pain is called nociplastic pain. Sometimes they call it neuroplastic pain, sometimes they call it central sensitization. Now, by definition, it is called chronic primary pain, but all of these are versions. And this is relevant because it explains why the pills and procedures are not enough. Medicines and surgeries are not often the answer, because the drugs work only in 30% of the people with only 30% efficacy. For those of you who've taken your paracetamols, your codeines, your tramadols in persistent or chronic pain, you can recognize that it doesn't work every time, it doesn't work that effectively, and it doesn't work for everyone. And the same with interventions. We've got problems with interventions as well, is that any injections or nerve blocks or steroids may work only for 2 to 4 months, and they give a window of opportunity. And indeed, when I was writing my book and I looked at the studies in the last 10 years, we've got lots of studies where they have done MRI scans on people of their hips or their joints, which don't have any pain at all. But their joints are showing cartilage tear, they're showing cartilage thinning down, they're showing disc bulges, they're showing disc degeneration, but they don't have any pain at all. So that means what you see on the scan is not at all correlating with the intensity of pain you may have. So all of this comes back to the part that when you have nociception, when you've got chemicals that are released at the site of injury, then that is where you're going to get the best benefit from medications or interventions or injections or surgery or infusions. But for that experience of pain that is coming up because your brain has decided it needs to protect you, we need to have a different set of strategies that you can see on the slide here. And that is what now the specialty of lifestyle medicine, there is a lot of interest in how we can help the nervous and immune system calm down. Cormac has mentioned all these points here. And so the lifestyle medicine option takes these 6 pillars and says, how can we help you do this calming of nervous and immune system down? Because conditions like autoimmune conditions like lupus, where the immune system is changed, conditions like fibromyalgia or migraine or irritable bowel syndrome, where there's no nerve damage or inflammation, these are going to respond very well to these conditions. I will finish my story here and my talk here with this story that I have. This is not a story itself. This is a patient who I looked after. She was diabetic. She had some low back pain that had been present for a little while, but then she had a flare up of pain, and that just got so worse that she became almost bedbound. All her immune chemicals were normal. There was no rheumatoid arthritis or autoimmune condition. There were a few psychosocial factors that didn't come out initially. But when she came to see me in the clinic, she was almost bedbound. None of the treatments had worked. None of the injections had worked. She was on all kinds of medications including strong opioids. Nothing had worked. And she'd been off work for almost 3 months there, and she had lost her job and had to move back with her parents. But with the support that we did, with the help of my team, with what we were able to put together, she is now, right now, holding down two jobs. I've not updated this slide, but she's now married. She's recently been on a honeymoon. She's been able to get back to running and enjoying the best quality of her life, and she's dropped all her medications. And that is what possible. That is where hope is there now, that if you understand your pain, know what it is, it can change the biology, and your systems can change and improve for the better when you know differently and your beliefs are different. Thank you so much for listening to me, and I look forward to the Q&A as well.
Thanks, Dr. Deepak. Thanks, Professor Cormac. We have a second segment where we have speakers again with lived experience, but we want to open up the space for around 15-20 minutes. I mean, a lot of us have been going through pain, and a lot of us work with people who live with pain. So if any of you have any questions to Dr. Deepak or Professor Cormac, please feel free to ask. Or if you just want to share your experiences of being in pain and what has worked and what has not worked, that's also okay. Yes, Chandni.
Yeah, thank you for the wonderful session, Dr. Deepak and Dr. Cormac. So I would like to just bring in a kind of an experience. Uh, as you had mentioned, we do see the doctors for an injury. So we are kind of conditioned. Of course, we may not be medical people to understand, but we are sometimes told that, okay, you are having this problem and you are likely to experience pain for a period of 6 to 8 weeks. So is that okay to be told? Because is it possible that we can recover earlier? Because we kind of get conditioned that, okay, this is the kind of thing that the doctor has told us, and we are kind of expecting that pain. So we sometimes don't know whether it's psychological. Oh, we're expected to have that pain for that 8 weeks. So can you please clarify on this? Thank you.
Deepak, I'll let you go first, then I'll follow on.
Oh, I was about to do the same to you, Cormac.
Get in there.
Yeah. So thanks, Chandi, for the question. It's a very common challenge that everyone faces, and you're right about the fact that there is a level of almost expectation effect that's set in, that somebody has told you it's going to be there for 6 to 8 weeks. So part of your nervous system is almost saying, okay, this is what I have to put up with. For a lot of people, it's helpful in some way to be given some kind of timeline. We all like to have a bit of timeline on being told when it is likely to end. And as medical doctors, we are also taught that for these kind of injuries, this is the usual recovery period. And so when a doctor tells you 6 to 8 weeks recovery time, that is a composite synthesis of the research he or she has been taught to say that on average, most of these injuries will heal within 6 to 8 weeks. And by average, in most studies, is about 50% recovery of pain. And that is what is the result of the information that's given to you, Chandi, in terms of when you should recover. But that is only the average. We always know that that only affects one big group of people, but there'll be many people who can very well recover earlier, and we should be trying to be more aware of why recovery can take longer. And now the data is there to actually predict to a certain extent who might be the people where recovery could be more prolonged, and what can we do to recognize early and mitigate it or put some strategies in to help them recover faster. So part of what you are experiencing is really an average information that doesn't work for everyone. There are people who can recover much earlier, and there are conditions where recovery occurs much earlier. And Cormac, I think, will go into it a bit more into that part there. Over to you, Cormac.
Cheers, Deepak. Yeah, no, an excellent question, and I wouldn't disagree with anything that Deepak has said when I'm talking to people who are coming in with a more acute episode of pain. I tend to use the idea of normal recovery times are sort of 6 to 12 week time frame. I say kind of, have you ever broken a bone? Have you ever had a friend or relative who's broken a bone? How long were they in the cast for? And it tends to be that 6 to 12 week time frame. It gives some good idea to them of what are normal tissue healing times, but emphasizing that it's just an average. It can range a lot. And really, I emphasize then about threat reappraisal, about trying to reduce the threat value of what the person is going through, and trying to highlight as best I can that the quickest road to recovery is trying to continue to do as many of your usual daily activities as you feel you can do. And I think the at this early stage, I think it's a real opportunity for us to try and do no harm, for us to not use language or behaviors that increase the perceived threat of the condition. That we should try and give supportive and encouraging information that will send the patient or the person towards a more active recovery approach. That's what will help to move their dial so that when we look at the average, they're on the lower end of the average rather than the upper end of the average. That's my only addition.
Thank you. Thank you so much.
Anyone else? We have some questions.
Yeah, Cormac, I was thinking whether you'd want to speak to the comment by Sri Krishna Yasaswi. Had the brain learn pain over time? I thought that would be right up for you.
Can the brain learn pain over time? I think the brain is constantly learning and changing and developing and rewiring. It's a very live organism, and I think when we develop persistent pain, it becomes better at producing the pain experience. It's a little bit like learning a new musical instrument. When you start off, you're not particularly good at it, but if you do it over and over and over and over again, it becomes really automatic. I've played the guitar for 30 years, and now I very rarely pick it up, but when I do, I can immediately do it. It becomes automated. So anything I think you do a lot creates that sort of learning within those matrices of neurons. But similarly, I think we have the capacity to change in other ways. So just like we have the capacity to, if you want to use the idea of learn pain in terms of your system becomes better at producing it under certain circumstances, then I think we can also unlearn. In other words, your brain becomes less good at producing it under those situations. And it's not easy to do, but I think taking the active approaches we talked about and that Deepak emphasized are really important steps in helping to change the algorithms so that the system is less likely to produce pain. And I think that's akin to unlearning how to produce pain. So I think it's evolving all the time. And just like it's got the capacity to increase and get better at producing the experience of pain, I think it also has the capacity to go the other way and get less good at producing the experience of pain. So I think it absolutely can learn and unlearn.
Thanks, Cormac. That's really helpful.
Dr. Deepak, we have many questions, but then because there was one specific question on fibromyalgia, and I know for a fact that there are people in the audience who have fibromyalgia, and I know you've done extensive work on it, but it continues to be a mystery. I mean, for people who live with fibromyalgia and the managing part of it, I mean, if you could just briefly share and answer that question, I think it would be helpful to a lot of others as well.
Absolutely, absolutely. I will do that. Thank you so much, Pratik, for highlighting me. Yeah, so I think that one came from NX629J. Okay, someone from the future, presumably. I will probably in this also cover the other statement from Abbas, who's talked about chronic illness and lupus. And there is a reason I want to bring these two in, because the newer research around fibromyalgia and lupus and many autoimmune conditions is this coming together of understanding what the nervous and immune system are doing together. For a long time, the word fibromyalgia, the way we talked about the word itself, it was thought that it is coming from the muscles or the fibrous tissue surrounding the muscles. And if there is inflammation in those muscles, that's the reason for the pain in many parts of the body, in the muscles or joints. So it was often thought of as a condition that is involving primarily the muscles or the ligaments or the fibrous tissue. We now know that in the last 10, 15 years, the research that has come through clearly establishes that it has nothing to do with the muscles or the fibers or the ligaments in itself. And in most people, there is no evidence of any inflammation, i.e., obvious inflammation in blood test or anything like that as well. Where we are now converging as a research part is to say that this condition is probably a reflection of the sensitivity within the nervous and immune system together. In chronic pain or in persistent pain, there is a big role of the immune system, not of the white blood cells that you get from your blood tests, not those kind of immune system cells, but there's a specific kind of immune cells within your nervous system called the microglia. These cells are the ones that are representatives of the immune system. They are the ones who are looking out for threat to the nervous system. They are communicating to the nervous system at all the time. And it is this cells along with the nervous system that together are firing away little bit what we call dysfunctionally. So they're not damaged, but they are just releasing different kinds of chemicals which are changing the way the nerves are firing. And it is this combination that is causing the pain in fibromyalgia that's happening. This is a realization that wasn't there. We were trying to treat fibromyalgia by doing more tests, more scans, or saying, let's do paracetamol, let's do codeine, let's give some painkillers because there must be some inflammation, so take more ibuprofen or diclofenac. Now we know that the cause is entirely different. The cause is actually the nervous and these particular cells in the immune system. The strategies to manage it are very different. And the reason I included lupus also in this is that in almost all autoimmune conditions, in about 40 to 50% of these autoimmune conditions, those microglia cells also start to become problematic. Apart from the main autoimmune things which fight against your body, the nervous system and the immune system within the nervous system get sensitized. So we see this kind of nociplastic pain that is seen in fibromyalgia is also seen in autoimmune conditions after it becomes chronic, within 3 or 6 months. So nociplastic pain, which responds differently, which requires a different set of strategies, about calming the nervous system, about calming the immune system, about what I call the lifestyle medicine-based, evidence-based strategies. That is what we need to do to manage the fibromyalgia pain and symptoms rather than having a new drug or something. I don't think we will ever get a super successful drug. I think some drugs are useful at the right time, like some nerve pain drugs may be useful, but the main focus has to be saying what else can we do outside of the drugs, apart from the drugs, to manage and calm and turn down this nervous and immune system sensitivity. That's the operational framework for fibromyalgia and for many of these pains.
We have a few more comments, Dr. Deepak, if you would want to answer any.
Yeah, I probably can. Thank you for Sri Krishna for sharing your symptom there. I'll just probably briefly go through what Rashmi talked about on muscle memory. I think for me, Rashmi, muscle memory is essentially still something that is coded by the nerves system that is supplying that muscle, and that coding and memory retention is done at the spinal cord and further up within the cells of the brain. And there is this phenomenon called embodiment. So, some of this information, and this is still emerging research, some of the information that we think is sitting only in the brain or spinal cord, it may not necessarily be brain or spinal cord, it may be actually embodied. It is through the muscles, through different layers of learning and memory, might not just be a preserve of the nervous system or the brain. It could be part of the wider body and the muscles themselves. Like the way I talk about this is like, if you think about, there's been some research done into how Federer activates his tennis stroke or Virat Kohli plays the strokes. You cannot say that he has thought about the decisions already. Like, these sports people do not have all their decisions in their brain or in the nervous system. Some of this is almost embodied through the implements and the muscles, the hand that they use. So some of this is at that level, which you can never quantify completely. So that's what I mean, that muscle memory is more deeper than just only muscles. So I hope that helps.
Deepak, I just see that Shilpi has her hand up.
Oh, yes, right. I think then we will probably better get another hand in there. Dr. Chanda, welcome.
Thank you, Dr. Deepak. So I think it's been such a wonderful hour listening to talk to both of you, because anytime somebody, and especially doctors, when they start talking about chronic pain, I get very nervous because I don't know what's going to come out of their mouths. And the science behind pain is often, Indian doctors have not caught up to it yet. I think we can agree upon that. So my question here is, how do we increase, awareness and, rectify the science behind pain? Firstly, for doctors, because if they are not informed enough, the patients can never benefit. And secondly, how do we rectify our own understanding of pain? Where do we begin? Because for most of us, when we search what is fibromyalgia, unfortunately, the top 10 links still say that it is a psychological issue. We do not even now, narcissisticity is something we just don't know about in India, right? Again, it is a recent term. Like, I know it's been coined rather recently, but in India, we are not required to keep up with the latest news, so we don't. And the patients, unfortunately, suffer because of it. So where do we situate this conversation into actual reality of improving things for people living with pain? Yeah, that's my question for you.
Thank you, Shilpi. I was telling Cormac before this webinar started, and I hope you don't mind, Pratik, as well. I'd want both of your views on this as well. But I was telling Cormac, we would very much want to listen to what you and Vachas were going to bring to this conversation later. Shilpi, we are quite keen to listen to that. part of it from a research perspective. That's why I was very keen for the pre-event survey and the post-event survey when I spoke to Pratik about it, is that we want to start setting the stage and the possible conversations to approach this problem both from a top-down and a bottom-up approach. The bottom-up approach is to see what is the appetite for something like Flippin Pain in India. What does it take for that kind of public health level grassroots emergence of some organization like that that can focus on public education? And the top down would be, okay, what are the conversations? How can we get some objective research to start emerging, get some of the medical schools or maybe some of my colleagues in medical schools to start researching on the Indian context for this, and Cormac will share, because we couldn't find any research that is coming up from the subcontinent on these aspects, the cultural narratives. And that's what Pratik has set the stage for. I won't say more into this, but maybe I'll ask Cormac, what are your thoughts about this, knowing that this is a challenge even that we faced in UK and the US?
Yeah, I don't think India is alone here in this challenge. I think it's a global issue that the biomedical model still dominates our understanding of persistent pain. And I think it's easy to see why. It's a very intuitive and simplistic model. And in the past, it's actually done very well for us. If we think about conditions like polio or the smallpox, the biomedical model through vaccines has been brilliant in eradicating these conditions. So it's worked for us before many, many times. If we think about antibiotics, how brilliant the biomedical model has worked in those situations. And like us all, if something has worked for us in the past, we naturally gravitate back to that for the next problem or the next challenge. The problem, of course, is that those sort of conditions I've talked about, they fit the biomedical model quite well. Whereas persistent pain or fibromyalgia or any array of many other conditions poorly fit the biomedical model. We're trying to fit a square peg into a round hole. And thus, we're kind of doomed to fail if we continue to try and apply this biomedical approach to what is a biopsychosocial condition. It takes time, I think, for people to move away from one model to the next, especially one that has dominated for so long. And I think certainly in the UK, we are getting there, but it is very gradual. And I think there are still, within the medical profession and allied health professionals such as myself, the biomedical model still dominates. But there is a slow growth in taking a more biopsychosocial approach. Obviously, I can't speak for the situation in India, but from what you guys have said, it sounds like it's a very similar challenge. The majority are very much in a biomedical place. How can we move them towards a more biopsychosocial direction? I think it needs to begin in our schools and in our undergraduate training. I think it also needs to take I would say this, but I think we need to take a public health approach. I think if we continue to try and talk to one clinician at a time, one patient at a time, one person at a time, we simply won't have the means and resources to communicate to all the people we need to. But if we can take a public health approach and reach many people at the same time to upskill everyone just a little bit, I think we could really begin to shift the dial on how we approach, rather than give a small minority a huge amount of training, so they're real specialists. If we could give a small amount of training to a large proportion of the population, I think that's where we'd see the biggest shift. But I would say that because I'm hugely biased towards a public health approach.
Thanks,
Thanks.
Cormac. Pratik?
Yeah, thanks, Professor Cormac. I mean, from my experience, I've did around 25
You're
people
breaking
living
up, Pratik.
across things in last 40. Sorry, I'll just put my video off and speak. Am I audible now? Is it better?
Yeah, better.
Yeah. So I was saying that in my experience of documenting stories and journeys of people living with pain across 10 countries, we've seen the similar pattern. I mean, we've seen the similar pattern of not seeing the person as a whole and looking at biomedical model. I also want to now bring in Vachas and Shilpi. We'll come back to you, Dipali, just maybe 10 minutes more and we'll come back. I see your hand. But because I have the tough job of being a taskmaster, so I'll just open it up a bit more. And we have Vachas with us, who's the chairperson of Lupus Trust India. Have had the experience of being with lupus since around age of 13, if I'm not wrong, Vachas. And we've been speaking, Doctor. And Vachas, how does one really their pain? And I would want to ask that.
Have you got two devices on, Pratik?
Hello.
We got an echo of you, Pratik.
Yeah. I think thanks a lot, Pratik. I'm assuming your connection's gone for a little while. Firstly, thank you for having me here. Dr. Deepak, I've read up so much about your work, and in fact, your book is on my read list for this week immediately. When Pratik told me about the work you've done, that was the first thing I had bumped upon. And Cormac, it was so wonderful to hear you talk about the most unconventional sides of pain, which is so obvious, but we never look at it that way. And then you ended up saying one thing which will stay, which is just one takeaway of this is that how we quantify pain and we correlate it with clinical markers is so, what do you say, dynamic and sometimes not very reliable. And so I think I will keep that with me. I would just like to quickly share my screen I'll try to keep it very short and I'll just quickly skim through a few things. So long story short, I was diagnosed with lupus at 13 and I still live with refractive lupus nephritis. And I have been on a cocktail of drugs, as they say, right from the basics of mycophenolate mofetil to a few commonly used monoclonal antibody drugs like rituximab and so on. But I also had the odd experience of having to import a lot of orphan drugs given my refractive nature of the illness, like obinutuzumab and belimumab. At least now belimumab is still more spoken about, but back then it wasn't. I still am severely immunodeficient because of the cocktail of drugs and lupus still being active, that I am on monthly infusions of IVIG, intravenous immunoglobulin, 40 grams, which has really taught me so much in terms of A, how expensive drugs are, B, the kind of army it takes to be able to support a patient who needs constant infusions, care. But I would like to bring everything back to the patient right now, the person living with pain. And as a patient alliance group, I co-founded Lupus Trust India as public charitable trust in 2018 with my rheumatologist, Dr. Padmanabha Shenoy. And today we have close to 2,000 patients engaging with us, online and few in person, but largely we are also on an offline basis. We are about 600 patients who manage to annually meet from various parts of India and keep that alliance patient support system strong and going. Well, just to come back to what we need to talk about pain and chronic illness, especially everything I'm going to be speaking will have a through the lens of lupus always, so bear with me. I think pain and chronic illnesses is often thought that it should be verified and triangulated using scans and reports and biomarkers. I learned it the hard way that it is not that way. Two, I also learned that, including using my own experience, that patients are overburdened trying to A, articulate, B, prove and explain their pain. And the burden of proof shouldn't be on the patient, and sometimes if you're not able to prove, you still have to acknowledge pain for what it is from the patient. That is something I learned after 6 to 7 years of living with lupus and undergoing aggressive treatment. So one thing I learned was to empowering patients with using the right lingo, the right language and the right words can really help them put it out, and that can then be given to the clinician, and then the clinician can interpret and triangulate it, and then we can jointly give the patient the best quality of life they need. But now that sounds very simple, but it is very complicated, especially when we are dealing with a multidisciplinary illness like lupus. You have multiple organs involved, and when the focus is often on curative aspects of saving the organ, often the pain aspect of it is pushed to the back burner. So I think I'd like to just address this. Dear patients, you must have heard words like psychosomatic, pain tolerance, you have an exaggerated pain perception, we understand it and all of that. And it's not your fault, and I just wish it didn't have to be that way. And which is why we have a group of, I think, forward-thinking, revolutionary clinicians here today on call, here to guide us on how we can place ourselves in this very ambiguous map of pain. And I also understand caregivers are a part of this. I think they also need to be so carefully and kindly handheld because they are lost. Sometimes they're going through worse because there's this burden of getting it right, the burden of not going wrong on the caregiver, like as if they had to get it all right. And it's just not like that, especially in illnesses like this. We need to understand that that's not the case. So I think something I'd just like to tell caregivers is that you can equip yourselves too with a lot of literature out there, very simple tools. And if there is one specialization in medicine today that acknowledges and gives caregivers equal importance, that is pain and palliative medicine. So I am so thankful to the specialization. You guys are the soul of medicine. And I learned that over the last 3 years when my journey with pain and palliative medicine began as a patient and then a patient leader. And to the dearest doctors who keep us alive, I would just like to say that when it comes to drug adherence, I understand that sometimes you just wish we followed and took our medicines the way you want us to take it. And I understand that we as patients often go through something called behavioral fatigue, where after some time we become a little risky and frisky with our behavior. We're like, how wrong can it go? So we might tend to not follow instructions. And I think that comes from a space of when there's that lack of space for patients to come and say that, no, I tried that drug and I don't think it worked, or that I'm in discomfort, or so I have a feeling that giving that space for patients to be able to confide in doctors, in you as a patient, I'd like to tell you that can really change how the treatment plan and progress of a patient. Overall, I think as a doctor you would be satisfied, as a patient we'd be recovering and happy, and caregivers would be on top of the world. So I think it's a win-win if these few things can be catered to. now I think it was a wonderful learning for me to be told that pain is now not just seen as a symptom, which I think Dr. Deepak and Cormac really touched over. So I'm not equipped enough to talk about this, but I think one thing I would like to tell you as someone living with an illness and working with patients through this Patient Alliance group is that pain need not always be clinically correlated with some tangible marker. I know when my anti-DS DNA was skyrocketing and my proteinuria and creatinine were probably, we thought it was a kidney failure, I had no pain and I was doing just fine. And at the same time, now, after 10 years of treatment, I'm dealing with severe chronic neuropathic pain and my everyday quality of life has dropped drastically. But then you might notice that my creatinine is stabilized and other markers are normal. So I think trying to put these two on the same, that one is a function of the other is very problematic. And I wish I were told that long before. That would have changed how my quality of life would have gotten better. So I know I learned this during my experience of the 1 month of staying with Pallium India with Dr. Rajagopal and his team who also treat me, is that WHO's definition of health, which is physical, mental, social, economic, all of that. And if you look at pain, irrespective of whether it's lupus or IBD or Sjogren's or scleroderma or whatever, I think pain manifests in different ways in each of these domains, and recognizing these can actually help us know when to intervene and when to escalate the suffering we're going through. Well, these are some of the books and literature and films that I watched and read about that immensely helped. Of course, Dr. Deepak's book is on my read list and I'm yet to read it. But I just like to say that in cases like chronic illness, when pain is subjective and it's also fluctuating and it's transient, I remember being told that actually many of the symptoms did not appear on my medical test, and that just completely baffled me. Like, for example, when I was diagnosed with zoster after my cyclophosphamide injections, which is severe immunosuppression, I was given tapentadol and gabapentin and I was knocked out. I was in good sleep, for days. But I never had pain, and so I never understood why I was given that. So when I said I don't need it, they tapered the dose and I was doing fine. But with the endometriosis pain that I had post my cyclophosphamide was excruciating. I was going hysterical. I was given paracetamol. So sometimes what happens is this is the patient's struggle. The burden of proof for me to tell you that, yes, you might think herpes zoster is probably more concerning, or you may have your own metrics of saying one is more than the other. But I think it's rather sad when patients have to get defensive and have to do this. So this is just, I'm sure a lot of patients or people living with these illnesses will be able to, if you were to look back, you will probably see these strange events in the past that probably never made sense to you then, and now you're able to actually piece together and find it strange. I just felt like understanding how there are some tools that can really help us effectively communicate what we're going through, especially when it's invisible disabilities and especially something like pain. Just look at yourself as a person. I remember meeting Dr. Rajagopal, the father of Indian palliative care. He asked me, so how are you doing? I started talking about my C3 complement markers and my C4 and my this thing. He said, no, but how is Vachas doing? And I honestly froze. I had no answer. So I'm still learning to do that, and maybe trying to grade each of these aspects of how WHO defines it, those 4 criteria, and then try to verbalize it and tell your doctors as to, when I go to work, I'm in pain, but that medicine you gave me is making me drowsy and I'm not able to sit through meetings. And I would really like to tell patients that it is not a sense of entitlement here. You very much should do that, because you are doing yourself a disservice and you're also not empowering the doctor to help you. So I think it has to be a two-way street, and I think this is more of a soft skill training that we need more than medical knowledge or any of that. So this is just tools and soft skills that I would really hope, Dr. Deepak, you would help us, maybe give our patients a little handbook on to how they can articulate pain and communicate that to their primary physicians and even other specialists that they meet in course of treatment. So yeah, I think this is something I'm really hoping that in the future, Pratik, we will be able to come up with these little guidelines where we are able to hand it over to patients in the form of a newsletter or something where they feel empowered enough to rely on these tools and communicate it to their team. Now, I think when it comes to drug adherence and treatment and patients following medication, I think patients, I would like to also tell you all, including myself, that it's okay to ask, what is this medicine for? When we talk about the Indian context, in general, we don't like anybody questioning. Like, if you can't question higher authorities, your parents, it's a problem. You can't ask your grandparents, bigger problem. There's this severe sense of hierarchy, and that also means that even in school, when you would ask a teacher a question out of syllabus, they would take it as a personal attack. But I think times have changed, and you can very well ask your doctors and they would gladly answer these questions that you have. So ask. I would once again request you all to ask, and I'm still learning too. I still get very intimidated when I'm with senior doctors to even ask, because I'm like, are they gonna now question my respect and loyalty towards them? But that's not true, and I think we should charity begins at home, so we should try to articulate ourselves and ask our questions. So I think some of the books that really helped me, which I do plan on reading, and Dr. Oliver Sacks, brilliant neurologist, and his storytelling is so beautiful. A Leg to Stand On. I love that book so much. And when a doctor ends up becoming a patient who's really suffered, they have the best worlds, unfortunately or fortunately, because then they really are able to step into our side of pain. And I thought that book was amazing. This is Dr. Raj. He is my palliative physician and has also adopted me as his granddaughter, fortunately. And I think I've really been able to rely on him when it came to communicating pain, the treatment I was given for the other specialists involved. I didn't know how to. In multidisciplinary care, we need these physicians to actually be in constant touch. There has to be that professional camaraderie that finally you're in here to help the patient benefit. And lastly, looking at caregivers part, as much as we talk about patients, I will again acknowledge caregivers. This is a picture of my mother and I when I was 18. I was 17, I think. And thank goodness for the ICU rules then. As long as you were a minor, you could have your parent or caregiver snuggled into the ICU with you. So I used to, be able to have that. But adulting is a little lonely in that sense. Now I have to just exist in the ICU alone. But I think I would really like to acknowledge how much pain caregivers go through. It may not be physical pain, but every other aspect of pain, psychosocial, as you all mentioned. So there are caregiver handbooks that are available, and I think we will also, with the guidance of Pratik and his team, maybe share some literature that caregivers can also rely on by the end of this. Since we also have your contact information, we will purely use that to get in touch with you so that you are able to rely and equip yourself with this literature that exists. Again, multidisciplinary pain, I just have one more slide left. These are some of the wonderful doctors who treat me. My primary physician, this is Dr. Shanoy. Then of course this is Dr. Bobby, my neurologist, and this is Dr. Karthik, my nephro, and this is Dr. Shanoy's dear friend who, when I had severe pain, came in from Bangalore just to see how they could help me with lupus related pain. So I've been immensely fortunate to have these group of doctors who can just pick up their phone and really talk, keeping everything aside, and just talk for the benefit of their patients. So that is the kind of multidisciplinary care I hope we are able to reach as a country, especially when we're dealing with complex autoimmune chronic illnesses. Lastly, I'm just so glad we have patient alliance groups in India really coming forward, joining hands. Like for example, today we have patients from lupus community, IBD community, fibromyalgia, you name it. So that's awesome, because at least now we are really coming and amplifying this, and hopefully that will result in policy changes, policy draft, and better inclusion for patients like us, so that we are able to get jobs and have a leg to stand on. So yes, if you feel you enjoy good films, because Blooming in Pain is again such a wonderful art community. It is about patience. It is about medicine and scientific temperament and all of that. But I still look at Pratik and the organization as a group of people who are artists fundamentally, who love whether it is visual arts or whether it's literature. Am I right, Pratik? If so, give me a thumbs up, please. Right. So please feel free to take a screenshot of this. This is a short film, and I think many of us have seen this on Netflix already. And these are some of the books I think that can be awesome. Battles of the Mind really helped me articulate the mental pain I was going through. I think I'll stop here. Thank you for patiently listening. Yes.
I believe Dipali has a question for us.
Yes, I do. Thank you. Am I audible?
Yes.
Okay. Thanks, Pratik, for organizing this, and thanks, Dr. Deepak, Cormac, and Vachas for sharing all your inputs. I've been diagnosed with fibromyalgia about 9 years ago. I'm in my mid-50s now. And I think from a point where I was not able to get out of bed or walk even 100 meters, I had to, leave my job eventually after 30 years of being in the corporate. I finally, I'm finding some level of I would say getting back to some sort of a normal functioning life. I do have extreme flares, but I think their frequency and intensity has been not as bad lately as it used to be. And it has required like a multi-pronged approach, as many of you have been sharing, right, in the last hour and a half or so. The bummer now is that in the last month or so, my daughter, who's in her mid-20s, also is showing signs of fibromyalgia. And I thought, like, you know what, I am learning how to deal with it and manage with it. And I think it's quite breaking my heart that somebody so young, and I know even younger people can contract chronic pain condition. She has inflammatory bowel disease, PCOD, and one more chronic thing of fibromyalgia creeping in. So I just wanted to understand, like, I know there can be a genetic predisposition to some of this, but I mean, I was hoping, nobody would have to deal with chronic pain, and seeing somebody this young. I just don't know what the prognosis could look like and whether she's going to be stuck with medications. I've been on pregabalin and duloxetine primarily, along with, other things that you try to put in the mix, not allopathy wise, but these are the two other allopathic medicines I'm taking. So I'm trying to understand, is there a way she may not have to be on medicines at all? Or I don't want to demonize medicines because it's helped me, but I thought she was just a little young, to get onto it. Thank you.
Thank you, Dipali, for the question there. And I would probably hark back to the particular comment that I made about our understanding of fibromyalgia now. I'm really sorry to hear about your daughter also having the same. You're right in the sense that I would say there's a slight variation. It's not genetic, I would be necessarily looking at, but I would say what's called epigenetic, meaning that if the ecosystem and environment is somewhat similar, then the expression of some of those genes will be similar, and there can be these patterns that come through. Right now, with the understanding of fibromyalgia that I have and which I shared earlier, I think there are many other non-drug ways of doing this. The aim is to do it in a consistent, predictable fashion that induces safety for the nervous and immune system over a period of time. And in the UK, a lot of this is going into a more lifestyle medicine based proper integration of all of these elements over a period of 8 to 16 weeks as a coached program. And that is how we help the nervous system learn new habits and retrain the neural circuits to actually enmesh these habits and embed them so that they become the new way for the nervous system to function. So I would say there is hope, but it requires a different set of approaches than just only drugs. So again, I wouldn't demonize drugs. I think there is value, but the timing is important and the understanding of what's driving it is also important.
Okay. Thank
Yeah.
you.
I've just received actually this one there. Hold on, let me see. I think it looks like Pratik with his audio had been accidentally booted out. Pratik, are we back?
Yeah.
I
Brilliant.
think he. Oh,
Yeah. Thanks. Sorry, I know Dipali, but I just couldn't hear what she said. But yeah,
That's brilliant.
have you answered, Dr.
Thank you. Yeah, I've answered Dipali's there. I think I was just aware that just for keeping to time there, Aditya, if you're able to put your question in the chat, I probably reckon it would be a good idea to sort of bring in Dr. Shilpi Chanda here. Pratik, do you just want to give your intro to Shilpi before we go?
No, I mean, I had prepared 4 or 5 lines, but because Vachas was talking about doctors being patients, here we are. I mean, Shilpi is a doctor, lives with fibromyalgia, has extensively worked within outside the community, to really bring voices of people with fibromyalgia outside. And I thought it would be worthwhile to listen from her. What does it really mean? Because for people like us who live with chronic pain, we don't like doctors much. From our biased experiences, and I realize all the messages coming in the chat that there's a lot of disbelief, but we are short on time. So Shilpi, probably we want to learn from you, and then we'll make it open and listen from others. I think people have a lot of questions, but yeah, all yours.
Thank you, Pratik. And yes, we do not like doctors in this community. So being one becomes a very complicated game sometimes. So yeah, hi, I am Shilpi, and yes, I am a doctor. I work in a primary mental health care setup. But today I'm here in my capacity as a person suffering from chronic pain and often at the very severe end of the spectrum for more than half a decade. So we've all been here for a while now. So let's just take a breath, calm ourselves down, take a minute to just recharge. I know it's been a long day. Yeah, let's go ahead. So I'm going to begin with 20 sentences and let's see if we find them relatable. It's all in your head. This is not a real disease. Am I just making it up? You're probably just depressed and anxious. You don't want to get better. You're not trying hard enough. No pain, no gain. You don't exercise enough. You exercise too much. You just want attention. You're just an addict. Don't think about it and it will go away. Have you tried vitamin C? Have you tried yoga? Loss of relatability to your peers and friends. Loss of credibility. Chronic and passive suicidality. Unable to articulate your pain. Unable to say what you're going through. Dying to express, but having nobody to listen to. Accusations of being hysterical. Grief for a life lost and lost dreams. Wondering if this ever gets better. These are some things that I believe people in the chronic pain community come across on an everyday basis. So a lot of what I wanted to talk about has already been covered. So I am going to be editing my speech in real time. So please bear with me. But let's begin with a few anecdotes. So in the ER, there comes a man. He's about 50 years of age. And this is in rural India, right? It's a tertiary care setup, but in rural India. This person has been coming to the ER every 2-3 weeks with persistent back pain. There is no significant change in his MRI, in his X-rays. So the doctors there aren't very kind to him. They keep asking him, why does he come here? They keep telling him that we can't do anything for you. After a long game of this repeating itself several times, they refer him to psychiatry, and the rest is history. Second, a young woman walks into the ER with very severe pain. This person's been suffering from chronic pain for a very long time, but they don't have much experience with the ER. So they go into the ER expecting care. Instead, they're met with accusations of drug seeking. They're being told, hey, if you're in so much pain, why aren't you crying? How are you able to talk to me? Third, so there's a friend of mine who reached out to me yesterday and he said, this is a treatment that I've taken and it has not worked for me. And my doctor's asking me how I'm doing. But if I say that I'm not doing well, he's going to be very unkind to me. He's not going to understand. The same doctor has been a voracious advocate for me. So you see how the same person can sometimes mean and be different things to different people. And this is how the landscape of chronic illness is. I never really know where to go, who to look up to. And as a provider, you also don't know who to refer to because things change person to person quite a lot. So people with pain often say that there are two fights that they have to fight. First is with the disease, and the second is with everybody else. Families who are worried but confused, doctors who are worried and still confused, workplaces that cannot accommodate fluctuating illnesses, society that is extremely comfortable with visible illness, but invisible illness is not something they know of. Right? The healthcare system itself, which in India does not acknowledge quality of life, wherein a lot of invisible illnesses operate. There's all this subtext every time you talk to a doctor. Your scans look normal, your blood work looks normal. Maybe you're anxious or depressed, thinking too much about it. And if you're a woman, there's this old ghost in medicine that quietly reappears, hysteria. Not often called hysteria outright, but its shadows are still there. We're still operating on that plane where often women with chronic illnesses and are quietly accused of hysteria. There are certain terms that doctors use that I'm not going to be speaking here today, but it's very much a reality. And so something very destabilizing starts to happen. Patients begin to ask themselves a question that no one should have to ask about their body. Is this real? And not because the pain isn't real, but because when enough people doubt your experience, doubt slowly migrates into your own mind. And now let's lay that onto the Indian social landscape. Illness in India is rarely just biological. It's deeply social. People occupy roles. You're a daughter, a son, a worker, a caregiver, someone responsible for keeping the machinery of everyday life running. Chronic illness disrupts that machinery. Pain does not follow schedules. It does not respect deadlines. Symptoms fluctuate in ways that makes the disease look unreliable. Some days you're fine, some days you're not. And people start hiding it. Families say things like, oh, don't tell people. keep this within the family. What will others think? Strangely enough, today is the very first time I am speaking about pain as a patient. I've spoken about it as a doctor. I've worked with pain. But today is the very first time I myself am admitting that, hey, I also live with chronic pain. So, there's a strange hush-hush around this illness. Very theatrical, very theatrical at times. Quite funny. That silence sends a very powerful message to the brain that pain is something shameful. You need to hide it. And as Indians, we're always taught that you should not disturb the social order too much. Meanwhile, the person living in that body is trying to make sense of a reality that medicine often, almost always, fails to explain. Chronic pain sits at a very unusual Chronic pain sits in a very unusual place in medicine. Fibromyalgia, nociplastic pain, chronic fatigue syndrome. They don't always produce the kind of markers that traditional medicine is trained to recognize, right? A while ago, a person sat across me and said, hey, I can handle the pain. I've learned to live with that. What I cannot handle is explaining and justifying it every day. Pain is exhausting, yes, but justifying it constantly is even more so. So people find themselves in what I sometimes think of as a hermeneutic maze, right? Someone says inflammation, another says stress, third one says lack of yoga, and most of them says, hey, there's nothing wrong with you. Get over yourself. You just need to go out and have a good drink. And again, so this is where the biopsychosocial model becomes very important. Patients trying to, assemble a coherent story about their own body from the fragments of everything that's happening. Biopsychosocial model, I believe, helps them frame these into a single picture. So people have already covered it, so I'm not going to repeat it again. So what do we do about it? Now, yes, I am a doctor, but today I'm speaking as a patient. So I'm going to be extremely blunt, and I'm not going to apologize for it. So you have to be very voracious with your advocacy, right? When you live with an invisible illness long enough, you learn something very important. You cannot outsource your understanding of your body completely. You need to become a participant in knowledge. Because who do you trust when even, the experts, the senior doctors, they don't know about chronic pain? You've read something, but the doctor says, hey, this is not true. So what does your family then believe? Do they believe you or do they believe that doctor? You know you're right. But there's a question now on your credibility. So first of all, it's very important for you to remember that none of this is made up. None of this is your imagination. This is real. And you don't need to let anybody tell you otherwise, right? This is this is the foundation of everything. You have to believe in yourself. Second is you need to grow a thick hide. The world is not a fair place for people like us. And there's a lot that comes your way. There is a lot of unkind things, a lot of unfair things that come your way. Now, this takes years to build. I know it's easier said than done. And even now, like if I'm talking in my support group, somebody and some people from my support group are here, people who constantly remind me that, you need to grow a thick hide. Don't listen to everybody, including doctors. Let them say what they're saying. You don't need to listen to everybody and everything. It is very important to filter what you know, are porous to. So you need to be very extremely sure about yourself and the science of chronic pain. All of this rests, right? All the things that we've talked about. The biggest, obstacle is that people don't know the correct science behind chronic pain. Your provider might not know it, so you have to. You need to go back. You need to learn about it. I know you're tired. Okay, I know you're in pain. And I also know that this is not easy. You don't know what is correct, what isn't, what is credible, what isn't. I think we're all going to help you out with that by, I think Dr. Deepak also said that they're going to send you some resources. So you need to know about your science. You need to be very sure about it. Be so sure that anytime somebody tries to undermine you or gaslight you, even in medical settings, you can say, no, this is not true. Again, an anecdote from my own life. I was at a neurologist's office recently. I was being tested for certain things and I gave my history. I've been taking a certain medication in a way that people with non-chronic pain don't ever come across. So this doctor sits and he tells me, hey, you're, abusing this medication, right? And I said, no, I am not. You don't know about chronic pain. And the doctor perhaps for the first time realized that, there is a different way. And patients don't always just listen to you. I can still, sort of remember the expression on his face and on my mother's face. We were both like, okay, what do we say now? But that is how sure you have to be. I'm not going to talk much about how you should, communicate to your doctor, because being a doctor myself, I have a different equation with doctors, which I believe a person outside of the medical community might not have. It's going to be extremely unfair if I, center my experiences in communication. And finally, you need to find a community. There is no other way to survive this, but with a community who understands, who goes through the same things that you do, and who keeps reassuring you and reminding you of what the reality is. You need to create boundaries and be extremely assertive about them. It is only when I told my friends in very clear words that if a venue does not have a lift, an elevator, I will not be going there. I will not be taking the stairs. That they started putting in efforts to look up whether a place is accessible or not. Before that, it was just something that, I'd said, but had no, got no response from. But it's only when I put my foot down that I'm not going to be there, there's not going to be an elevator, that they started thinking about it. So your boundaries and communications need to be extremely, assertive. And finally, this is going to come as a very bitter pill and something that is a lifelong process. You have to stop looking for the validation that will never come. A lot of us, we keep expecting our family members, our friends to remember, to understand. You go a year, 2 year, 10 years into your journey and you expect, hey, it's been so long. Maybe finally they'll start understanding, and they don't. And the truth is that perhaps they never will. And that is something that you need to understand, that you need to be cognizant of. It's not easy to be okay with it, but you need to save your energy to expend upon, surviving this life instead of expecting people to make space for you. What do you do when your family does not understand? You lean on your community. That is why community is very important. One of the most powerful treatments not treatments, but things in chronic pain is surprisingly simple. It's a moment when somebody sits and says that, hey, I believe you. And I'm here to tell all of you that, hey, I believe you. Thank you.
Thanks, Shilpi. Thanks, Vachas. Shilpi, we're just near time, but we'll take a couple of more questions. But before that, Dr. Deepak, if you can just put in the post-event survey on the chat, and if you could also show us the QR code, we can just do that and then take it on from there. Guys, for some of you who had done the pre-event survey, we would request another 2-3 minutes of your time and fill up the survey as we are closer to the summation of this event, and this would get us a sense of how did we do and what were the perceptions which were changed and how can it be a bit better.
Thank you so much, Pratik.
2-3 minutes.
Actually. Yeah. So I've just put the request and a little bit of call it incentive, call it just the request for staying with us, for listening to the wonderful experiences from Vachas and Shilpi. Thank you so much for sharing what's happening and what your personal experiences have been. It's a lot that I hear similarly from some of my relatives and my friends back in India as well, and even though I've got lots of medical friends as well, when you are on the other side of the table, the experiences are unfortunately quite similar to what you've outlined. So thank you for sharing that. Thank you all for staying here. So the QR code link is there. I'll also put a little bit in the chat as well, a similar kind of Google form if that's easier for you. But thank you so much for this part. One moment. Let me just share. I think so that part there, and I'll just put something in the chat. If you're just able to fill out this particular information there, and then what will happen is when you fill out that information, it's again just going to take less than a minute, and that will then, once you fill the form and submit the button there, you will get a link to the drive, which has got these folders just to start you thinking on what can we do to calm the nervous and immune system. This is what I work with a lot of my patients in here, just to get them thinking. Sometimes they need support, sometimes they can, just like the advocacy that Shilpi and Vachas have talked about here today, this is just to give you that little bit of confidence, little bit of empowerment to say, what can you do if you're not going to get to the right kind of doctor or the right kind of healthcare professional who can listen, support, and validate you. The resources are quite similar to what Cormac has also said, and this is what I give here. Necessarily, if you make me aware of other organizations in India who've developed that, then I'd be happy to learn, and that can be knowledge we all bring together. Otherwise, this may be an opportunity for us to start putting together something with the help of all these patient advocacy organizations that you're all leading. And of course, some of the other resources are all PDFs which you can have a look, use for your pain, chart out your template, and that will give you a much more better understanding of your symptoms. Hopefully, for those of you who have pain and who have joined this, just take that one step back to look at your pain in a very different fashion, and this just gives you the resources to do that. So yeah, all of that is available once you just fill out that form and press the submit button. Less than a minute to do so. In the meantime, please, any questions, anything that you want to keep asking, please do. We can use the time here, and me and the organizers, we can stay for another 5-10 minutes here if that's you feel is required. But for others who need to leave to get ready for the match, to get ready for your other activities in the evening and for the rest of the week, thank you so much for staying with us.
Thank you. Thank you so much.
Thanks.
Cormac, are you okay to stay on back for another 5-10 minutes? If you do want to leave, then
Sure, absolutely. Yeah, happy to stay for a few more minutes.
fine.
Shilpi, I thought your story was fantastic. So well communicated. I loved your 20 opening sentences.
Yeah, absolutely.
Immediately, you could see everyone relate to those. And I think that's a really good sign of a good communicator when everyone goes, "Oh yeah, that's me." Uh, um, uh, I sometimes describe it. I've heard it described as a thing called narrow casting rather than broadcasting. When you're talking to lots of people, but everyone thinks you're talking to them. It's a real skill. So yeah, beautiful, very well done.
Thank you very much. I think these are things that we come across on an everyday basis. And yet, because, there's lack of communication, so most of us don't know that we're all listening to the same things.
Mm-hmm.
Sometimes bringing it in gives you a perspective.
Mm-hmm. Mm-hmm. Absolutely. Absolutely.
There was one on
Pratik, do you want to go on to video
gym
off? I think you're breaking up again.
this when
I think Pratik's video and audio bandwidth is probably, I think it's got frozen now actually. I'll just take over that. Thank you, Daritri, for the information. Pratik, are you back with us?
Yeah, I'm audible.
Yes, that's better.
No, I was saying that there was a question on gym, and with me, I mean, when with onset of pain, I just didn't move for 3 years, and I was in bed for around 12 months. But when I actually started walking and doing physical exercises, there hasn't been a single day where physical exercises have harmed me in terms of pain aggravation and increasing the intensity. I mean, that has been my personal experience of being with fibromyalgia, that it has always benefited me.
Absolutely. That's very helpful. Thank you for sharing
I'd like
that.
to add something.
Yeah, Shilpi.
So my experience has been absolutely on the opposite end of the spectrum. Anytime I've tried yoga, I've tried to go to the gym, it's, the retaliation on my body has been very bad. So while yes, sometimes I swim and that is a little kinder to me, but I have a lot of like movement intolerance. So,
Yeah.
both those things are true. And
Yeah.
and I think you need to understand that, again, you have to be your own expert and you have to understand what works for you.
Yeah, of course.
Absolutely. I think that's a very good point there, and we've seen both sides of the spectrum there. I think where we are approaching from an evidence-based Shilpi, and you'll be familiar with this as well, is that the movement is considered as what is safe for your system to do and what you've done before that you feel ready to do. So generally, we don't suggest any new sudden movements or things to be taken up. It's often what can you start with something that is at a really small amount, that is manageable, that feels safe? Is that something you'd be able to do? Is usually the opening gambit for a lot of now pain aware movement therapists and physiotherapists in the UK. We are all approaching it from that perspective of what can be contextually right for the person at that time, rather than having playbooks for this is what you need to do for 6 weeks or 8 weeks.
Yeah.
Cormac?
Cheers, Deepak. Yeah, I think for me, it's a kind of about valued goals. What does the person really want to do? What excites them? What enthuses them? What makes them want to kind of get up in the morning and do? And that's what we should be trying to help people to do.
Yeah.
And a lot of the time, that does require a degree of movement. For in some cases, it's quite a small amount of movement. For others, it's quite a lot. And I think it's about working with that person to help them get to where they want to be with that. And I think most patients and most people can relate to that, and kind of they warm to that idea rather than, and it allows them to kind of take the driving seat a little and decide what it is they'd like to do for their goals and their management, and then you can kind of help them along that way. And for some, that will absolutely include things like exercise and gyms and that sort of thing. And for others, it won't, and that's okay. For me, it's all about, as I say, valued goals and trying to reduce threat of doing those valued goals, because I think if we can, that helps the person to engage with them. Yeah, that's just my 2 cents.
Brilliant, Cormac. Thank you so much for that bit there. I'll just Aditya, I might ask you to actually unmute and ask your question again, just so that I can be fully clear before I answer it. Before I ask you to do that, I might just give Manu Dilip his question on MCAS. Yes, MCAS, which is written in the chat, is called mast cell activation syndrome. It's a specific kind of immune cell that can be activated. We think that it's one of the immune cells that can be activated, and in a small group of people, that activation of those immune cells and the chemicals they release can cause symptoms, including pain. So it's one of those conditions, Manu, where we recognize the immune and nervous system is active, and it's one of those conditions which gives us proof that both these systems are problematic in many cases of chronic pain. But MCAS is still, a lot of research is required. We need some objective blood tests and markers to be very clear about it. And there's still no guaranteed treatments for it. It still comes under the overarching thing. What I told you is, can we focus on how we can calm the nervous and immune system down using multiple approaches rather than saying one drug or one injection, etc. I hope that's helpful. Aditya, are you still with us? Do you want to unmute and ask me the question, ask me and Cormac the particular question? I did not fully understand it.
Yeah. Am I audible?
Yes.
So I wanted to ask you, like, when we say chronic pain, so is that physical pain or something else?
Okay. And the second part of your question, you shall I just stick with that part then at the top level, and we take a chance at answering it, me and Cormac? Would that be all right?
Yeah. Sure.
Yeah. So my view is that chronic pain is the umbrella term for the sum total of all the experiences. It may start with a physical structure of the body, but it is not so. What the person actually feels and tells me in the clinic, I will always think of it as a combination of something that may be coming from a part of the body, if there is evidence for it, and something that is a sum total of what I talked about in my talk, wherein the nervous system is deciding whether to protect you or not. So based on that, it can amplify it. So the best example I give is, if you are having a sprained ankle, that pain that comes from a sprained ankle will be, let's say, X amount. But if you're having that sprained ankle on a football field just about when you're about to score a goal for your team, or let me put it in cricket term, when you're about to have the spasms that Finn had and still he scored the game and finished the game for New Zealand, that will be a different kind of pain that he will feel versus when Finn Allen is about to cross the road and a bus is about to hit him and he has a sprained ankle. The intensity might be very different, because in one he's protecting his life, and another he's about to make a difference to his country. So the amount of pain that he will feel, even though the physical pain of the sprained ankle is the same, what he will complain about, or the intensity, is going to have an extra dimension. So that is what is the persistent pain, is that extra dimension plus any physical that may be there. But we know from what you heard today that physical thing need not be there in many people. Scans may not be correct. Cormac, anything to add in this?
Thanks for that, Deepak. I think that's a great question. And I think it's a question that my students, so I teach at Teesside University and healthcare students, and I get this question all the time. What, is physical pain different to psychological pain? And for me, it's a really false dichotomy. For me, there is no physical pain. There is no psychological pain. It's just pain. And all pain will have an element of the biological, an element of the psychological, an element of the social. And the different makeup is as different as there are human beings. And fundamentally, whoever that person is, starting off from a place of belief and compassion and humanity is the great place to start. If you start there, everything else flows from that. And I suspect Shilpi would have an interesting, because she comes from both of those worlds. That, do you know what I mean? I'd be really interested to hear what her thoughts are. I suspect you've been told several times, Shilpi, that your pain is a psychological pain, and you've probably wanted to hit the person. It would be my guess, but because you're a very a professional and nice person, that's not what you've done. But I could be completely wrong. Shilpi, what are your thoughts?
Repeat the question, please.
So it was kind of what's the difference between psychological pain and physical pain? Are they different things?
So I think you're quite correct when you say that it's a false dichotomy. I think the narrative itself exists because, when it's psychological, it can be dismissed, it can be undermined.
Mm.
And unfortunately, in India, psychological means not real, right? It's all in your head.
Mm-hmm.
My answer to that is often, where else is this supposed to be? Because if my brain's not in my head, then we both have bigger problems to deal with. And so I believe this dichotomy and all these, doubts, which is there to dilute the problem itself. I've been told several times that, your pain's just psychological. Once by my psychiatry professor, he said, they're just trying to turn you into an addict. That's it. There's no pain. It's all in your head. And the problems again, when you don't have a counter narrative, that is what you ought to believe. Because there is no other information available to you. So again, this is where, communication, especially healthcare communication, is important. To create these counter narratives, to create this information, to at least put a doubt into people's mind that, okay, maybe something else also exists.
Yeah. Absolutely. I totally agree. I often think that the most important and interesting things can't be seen or proven. Love is the one I always kind of come back to. It is, it's what motivates each and every one of us to get up in the day and do the things we do. You can't see it. You can't quantify it or demonstrate that one type of love is real and one other type of love is not real. And I think pain really fits into that category. It is an extremely powerful and universal experience. Can't see it, can't quantify it. But we have, I don't know, it's strange that often there's an inherent doubt from others about it. And exactly why that doubt exists, I don't know. It's extremely complicated, but I know it's extremely frustrating for those of us either experiencing it or in the know of it. Yeah, I really, for all those experiencing persistent pain, I think that must be one of the biggest frustrations.
So I work in mental health. So that entire category falls into the same, narrative. Is it real? Is it not? Subjectivity is something that we have a lot of problem accepting. That, different people have different subjective experiences. Also, I think there's this thing where a person's very resistant to believing that you can do everything right in your life and still someday end up extremely sick. There's a lot of resistance, this thing that you need to do something to get ill. Oftentimes chronic pain just happens to you. Mental illness again happens to you. And there's nothing you can do to, outrightly protect yourself against it. So I think one of the reasons might be this.
I think you're right. I think I think what you can do is push some of the dials in your favor. Do you know what I mean? You can. There are, as with life, there are things that are within your control, and there are things that are out with it. And I think what we all should try and do is take the things that are within our control and do them to the very best of our ability. Eat well, sort of try and have good social networks. Try to move and stay active if we can. Try and get good sleep. Try to reflect upon our own fears and worries and anxieties and talk about those with other people. And try and learn as much as we can about our condition or about our health. And I think that puts us in the best possible place. But I don't think at the same time we should be fooled into that doing this is just an immediate panacea for everything, and everything will be magically okay.
Brilliant. Well, thank you so much, Cormac, for that. Thank you, Shilpi. I just wanted to probably realize that we're almost 20 minutes beyond, wanted to help us all get on with our day there, if that's okay.
Just want to go and watch the match, Deepak.
Yes, that is one of the reasons I haven't said anything much there, but no. Thank you so much once again for agreeing to fill out. Aditya, I just saw your hand up. Hopefully it was a legacy hand, and Cormac has answered your query as well. But Pratik, are you still with us? Are you able to, is the audio?
Yeah.
Brilliant. Fantastic. Well, once again, as a co-organizer, I'm very grateful to Simi and Pratik today for putting this all together, for getting and reaching out to Vachas and Shilpi for bringing it together. So many thanks to Cormac as well for bringing Flippin Pain in and presenting an opportunity and an option for us to look at pain awareness differently going forward. These are just baby steps now. So thank you so much for filling out the pre and post event survey. We'll keep you informed on there. And as you probably realize, one of the things that Blooming in Pain, Pratik wanted to do is to start having this community that can form, that is cross, not just all the individual condition organizations, but to see whether we can generate something that's more meaningful for chronic pain across the society, across country as well. And that will really help us. This kind of work and output from here today, the conversations we've had will really make a difference in setting the stage for that and helping look at some proper research that we can do and the cultural narratives that we should capture make it true. Pratik, any words from you finally before we close? I hand that over to you. Many thanks for having me, and many thanks all of you for attending and staying back today.
So, thanks, Dr. Professor Shilpi and Vachas. I mean, everyone. It's been a labor of love, quite frankly. I've been in pain myself for last 2 days and missed out our best friend's event yesterday night, and the last 48 hours have been terrible in that sense. But I mean, I think last 3-4 months of conversations with you, and I've been very clear. Being in India, I'm a coalition guy. I mean, I don't want to work separately, individually. Um, I love seeing the political alliances as well as social alliances. So I mean, thank you so much. I think we all of us have been in pain. I mean, including me, and a lot of my friends from the community have joined in. I've been here for 2.5 hours, and I know being in a space for 2.5 hours is not easy. And it's difficult to just sit and listen for people who haven't shared. But thank you so much. A lot of gratitude and love from me, and I hope we could do this more often and build something sustainable, as all of us were saying and thinking. Let's really create resources for us and for our caregivers, because I think it's our families and friends and loved ones and also colleagues who deserve to understand the situation a bit better than what it is right now. Yeah.
Brilliant. Well, have a good day then, all of you. Wish you all the best for your week and coming weeks ahead. And thank you for being part of today's webinar. Have a good. Bye, Shilpi.
Bye-bye. Thank you.
Cormac.
Thank you, everyone.
Bye all. Thank you so much. Bye-bye.
Bye.
Bye-bye.